This briefing covers the 2026 update to NICE Guideline NG28 for the management of type 2 diabetes in adults. We are moving beyond simple glucose lowering toward a comprehensive strategy of organ protection, incorporating the latest evidence on SGLT2 inhibitors, GLP-1 receptor agonists, Tirzepatide, and continuous glucose monitoring. This guide helps healthcare professionals individualize care and optimize pharmacotherapy based on the most recent clinical standards.
To understand the 2026 update, we have to recognize a fundamental paradigm shift. We are moving beyond glucose control. Traditionally, we treated type 2 diabetes as a sugar-centric disease, but we now view it through a triad of glycemic control, organ protection, and weight management. The big three updates driving this change are, first, the move to SGLT2 inhibitors as standard early therapy for nearly all patients. Second, a massive leap in weight management with the introduction of Tirzepatide and broader GLP-1 use. And third, the standardization of continuous glucose monitoring, CGM, technology for anyone using insulin. We are no longer just lowering numbers, we are proactively protecting the heart and kidneys from day one. Our starting point remains individualized care. This involves shared decision-making that balances patient preferences and values against the risks of polypharmacy. Crucially, a pre-assessment of cardio-renal status and frailty is required before any new pharmacotherapy is prescribed. Management must prioritize conditions like heart failure, chronic kidney disease, or established cardiovascular disease, which may override standard glucose targets. Lifestyle modification is not a one-off event. It runs concurrently with all medication. Patients should be offered structured education at diagnosis with annual reinforcement. Dietary advice must be evidence-based and tailored to the person's needs, focusing on high-fibre, low glycemic index foods like whole grains and pulses. For eligible patients, referral to the NHS Type 2 Diabetes Path to Remission programme remains a key consideration for achieving weight-related remission. Standard HbA1c targets are set at 48 millimoles per mole for individuals managed by lifestyle or medications with no risk of hypoglycemia. This target is relaxed to 53 millimoles per mole for those using medications associated with hypoglycemia. Technology is now an integral part of standard care. We offer intermittently scanned CGM, flash, to adults on multiple daily insulin injections who have recurrent or severe hypos, impaired awareness, or disabilities that prevent capillary monitoring. Real-time CGM may be considered as an alternative if available at a similar or lower cost. For all patients using this technology, we must provide education on how to interpret data and ensure they still have access to capillary blood glucose strips as a backup. The pathway to treatment is now defined by 7 distinct clinical scenarios. Once a diagnosis of type 2 diabetes is confirmed, the healthcare professional must assess the patient's cardio-renal status, future cardiovascular risk, and clinically significant frailty. Treatment is then selected by matching the patient to their dominant clinical profile, whether that is a lack of comorbidities, heart failure, atherosclerotic cardiovascular disease, chronic kidney disease, obesity, early onset diabetes, or frailty. For patients without relevant comorbidities, dual therapy is the new starting point. We offer modified release Metformin alongside an SGLT2 inhibitor. To ensure safety, start Metformin first and titrate to ensure no side effects before starting the SGLT2 inhibitor without delay. If Metformin is contraindicated or not tolerated, the SGLT2 inhibitor should be offered as monotherapy. In scenario 2, we prescribe for organ protection rather than just glucose lowering. For heart failure, a combination of modified release Metformin and an SGLT2 inhibitor is critical for outcomes regardless of ejection fraction. For those with established atherosclerotic cardiovascular disease, we adopt a triple therapy approach from the outset. We offer modified release Metformin, an SGLT2 inhibitor, and subcutaneous semaglutide at doses up to 1 mg once a week.
This specific GLP-1 receptor agonist is recommended because it demonstrated the most cost-effective and clinically significant reduction in major adverse cardiovascular events, MACE. Management of chronic kidney disease is guided strictly by the patient's eGFR. For an eGFR above 30, dual therapy with metformin and an SGLT2 inhibitor is standard. If eGFR falls between 20 and 30, metformin is contraindicated and must be stopped. In this bracket, we use dapagliflozin or empagliflozin combined with a DPP4 inhibitor. For an eGFR below 20, consider a DPP4 inhibitor alone. For patients living with obesity, we begin treatment with metformin and an SGLT2 inhibitor. If the individualized target is missed after 3 months, we escalate therapy by adding a GLP-1 receptor agonist or Tirzepatide. For women of childbearing potential, it is essential to discuss pregnancy risks and ensure effective contraception is in place, as weight loss may also improve fertility. For patients diagnosed with early onset type 2 diabetes, those under the age of 40, we adopt a highly intensive initial strategy due to their high lifetime risk of complications. We offer modified release metformin and an SGLT2 inhibitor, and should consider adding a GLP-1 receptor agonist or Tirzepatide right from the start. If further escalation is needed, we then look toward adding a sulfonylurea, pioglitazone, or insulin-based treatments. Again, for women of childbearing potential, it is essential to discuss pregnancy risks and ensure effective contraception is in place. In the context of frailty, our goal is to use the smallest effective number of medications to avoid polypharmacy risks. Modified release metformin remains the primary choice. We perform a specific SGLT2 check. These inhibitors should only be offered if the patient's level of frailty does not place them at risk of adverse events like volume depletion, hypotension, and falls. If these risks make SGLT2 inhibitors unsafe, a DPP4 inhibitor should be used instead. Implementing therapy follows a stepwise approach. Step 1 is starting metformin and checking for tolerability. Step 2 involves adding an SGLT2 inhibitor once metformin is tolerated. Step 3 adds a GLP-1 or Tirzepatide once the SGLT2 inhibitor is tolerated. Clinicians must be vigilant regarding diabetic retinopathy risks if HbA1c is reduced rapidly. When individualized targets are not met during escalation, consider adding a DPP4 inhibitor, but only if the patient is not already on a GLP-1 or dual GIP/GLP-1RA, Tirzepatide. A new diagnosis of cardiovascular disease should prompt the immediate addition of semaglutide. Above all, follow the safety rule. Never combine a GLP-1 receptor agonist or Tirzepatide with a DPP4 inhibitor, as they act on the same pathway and offer no added benefit. Continuous review and deprescribing are essential for ongoing care. If a patient experiences gastrointestinal issues on standard metformin, switch to a modified release version. GLP-1 or Tirzepatide treatments should be stopped if the patient's BMI drops below 18.5 or if the medication is ineffective at meeting glycemic targets, unless it is required for cardiovascular protection. Patient safety regarding SGLT2 inhibitors is paramount, particularly concerning the risk of diabetic ketoacidosis or DKA. It is vital to counsel patients that DKA can occur even with near normal blood glucose levels. We must teach sick day rules. Suspend metformin and SGLT2 inhibitors during episodes of vomiting, diarrhea, or intercurrent illness. These medications must also be paused before surgery or during ketogenic diets. To summarize the NG28 update, we must treat the person, protect the organs, and manage the glucose. Identify the correct clinical scenario for each patient, initiate organ protective therapy early, and adjust regimens based on renal function and individual safety risks. Following these pathways ensures that pharmacotherapy is optimized for the best long-term outcomes. Prescribing disclaimer and clinical caveat. This presentation and the associated visual guides are intended as a summary of the NICE Guideline NG 28 February 2026 update. They are designed for educational purposes and to support clinical decision-making, but they do not replace the necessity for individual professional judgment. Clinical management must always be tailored to the specific needs, preferences, and comorbidities of the patient in front of you. Please be aware that while this guide outlines standard pathways, such as eGFR thresholds for Metformin and SGLT2 inhibitors, pharmacotherapy is subject to complex variables. Healthcare professionals must independently verify the current Summary of Product Characteristics (SPC) or the British National Formulary (BNF) for every individual drug mentioned. This is essential to confirm the most up-to-date dosing schedules, especially for patients with renal or hepatic impairment, and to screen for potential drug-to-drug interactions that may not be captured in this overview. Special vigilance is required regarding contraindications, such as the absolute requirement to discontinue Metformin when a patient's eGFR falls below 30. Furthermore, clinicians must ensure that safety protocols, including sick day rules and the monitoring of euglycemic DKA risks, are communicated clearly to patients according to the latest safety mandates. CMB Communications provides this material as a navigational aid only. We accept no liability for clinical outcomes or prescribing errors resulting from the use of this guide. The ultimate responsibility for the safe and appropriate prescription of any medication lies solely with the healthcare professional, who must exercise their clinical discretion and adhere to local trust or health board protocols at all times.
Like and subscribe.